Yeah. So hi all, big welcome to the session. This is going to be a very informative session, and let's keep it as more interactive as possible. Just a quick introduction about Dr. Lalit Mittal. He is the founder and director of Giggles Clinic and My Own Space Child Development Center for Autism, ADHD, GDD, learning disabilities, and Down syndrome. He's working as a consultant, developmental pediatrician in CK Birla and Fortis Hospital, Delhi. And he has a graduation in MBBS from prestigious Mysore Medical College and Research Center, following which he completed his DNB, Diploma of National Board in Pediatrics from Indraprastha Apollo Hospital, Delhi. Welcome to all of you again. Over to you, Dr. Lalit.
Thank you. Yeah. So, am I audible?
Yeah, loud and clear, doctor.
Okay. So, welcome all of you. So, the today's topic, which has been given to me, is how to disclose the diagnosis of autism to parents in office practice. Now, this is one of the most challenges question that we face as pediatricians because just putting across the word autism spectrum disorder or autism to the parents will definitely bombard you with a lot of questions and reactions. So you have to disclose the diagnosis. On the same side, you have to look into the sentiments. How you dispose the diagnosis, how you dispose that communication matters a lot. So let's see how we can come across this challenging question and the scenario, which majority of our pediatricians in day-to-day life must have felt and must have experienced also. And due to our busy schedule, we cannot give that much time in counseling. So let's see what are the ways which we can reduce this burden of putting across this diagnosis of autism to the parents and how the acceptance might come little better. So disclosing a diagnosis of autism to parents can be challenging, but it is essential to handle the conversation with sensitivity and compassion. Now, this is one of the most important things. See, putting across a word diagnosis, your child is having an autism spectrum disorder is very easy. You can just look at the child, you can make a diagnosis because more or less it's more of an observational finding than doing you using tools like ASD, maybe ESA, or maybe cards. So cards and ESA, whatever tools which we are using, these are additional or they will help in making your observations go in hand to hand. But the major diagnosis and observation is what you see in the clinical practice, which you observe the child in your OPD. So all those observations can give you a clear picture depending upon how much expertise and how much experience you have in seeing these children on neurodiversity. So the most important thing is the conversation should be handled with sensitivity and compassion. Just putting across your child is having an autism spectrum disorder and it's a neurodevelopmental disability, it requires lifelong assistance, can put you bombarding with a lot of questions. There might be so many things which might be difficult for you to handle during that OPD practice. So when you put a word across autism to the parents for the first time, what thoughts and dilemmas do you think can come to the parents' mind? So as a parent, a lot of things come to their mind. Why did it happen to my child? How did it happen? Are we the culprits? I did not eat proper in my antenatal period, or that could be the complication which resulted in autism spectrum disorder. My child was absolutely fine till 2 years. Then how suddenly, doctor, you have labeled him as autism in just 1 year? There are so many questions irrelevant, so many confusing, so many questions that you may get irritated again and again, but they are just beating around the bush. But the important thing is we should not get irritated by these things. Suddenly we saw him or her decline. So my child was absolutely fine till 2 years. And then suddenly we saw that there are declining his milestones. Is the screen the cause? So all those things and thoughts and dilemmas come in the parents' mind. So these situations have to be handled. Just putting a word autism is not enough. you also need to handle these thoughts and dilemmas and problems which come into the parent's mind. They might suddenly go into a mental setback. So all those things, all these complications, you have to prepare in your mind. You have to be prepared with yourself before doing this disclosure of diagnosis. So there are a lot of things which come. It's an unplanned journey. So parents usually go through this unplanned journey. This is a way the Kubler-Ross stages has given this 7 stages. These stages are very, very important. The stage of grief, the stage of denial, the stage of anger, bargaining, depression, acceptance. Now, when you put a word across the diagnosis of autism to the parents' mind, to the parents, the first thing which comes is the grief. Acceptance doesn't come easily at all. Believe me, no parent will go for an acceptance of autism on a single go. They will show you a sign of grief. They will show you a sign of denial, which is very, sir, ye to ho hi nahi sakta. It's not possible. My child is on the spectrum. If you put across a word of spectrum rather than using a word developmental delay, they might be a little more comfortable. But if you put a word ASD, that becomes a real period of denial, anger, grief. As I've told you, they might bombard with questions. They might be bargaining. Are you sure, doctor? Are you sure this is the cause? Are you sure? Can we look into a more? They might go into the second opinion. They might even not turn to you again, thinking that you have put on the word autism across them. So all these things you need to look across. So as a parent, as a professional, as a clinician, our aim is that this stage from grief to acceptance is takes a very long period. You have to reduce this period so that their acceptance comes easily and gradually, but early. You might label a child as autism at the age of 1.5 years, but that acceptance come by the age of 3 years, and by the time the period of early intervention and all those things, we lost that period because many a thought comes, ye to aisa hi hota hai, he might be a late toddler. XYZ person also didn't speak. You put him in a school, he will start speaking. Doctors say like this only. So all those things, even your grandmother, grandfather, especially the grandmothers who are our senior pediatricians, generally they give their thoughts that your father also didn't speak. He also became late. He spoke late. So all those things come. As a result, we start thinking, oh, my child would not be on autism. The doctor has just told us, so don't worry. He will slowly and slowly gradually build up. But that period doesn't come till the child reaches to the age of 3 years and he starts showing all those behavioral symptoms, not adapting in the school, and then again a clinical consultation takes up, and then finally the acceptance comes. Though at the first stage of 1.5 year to 15 month, doctor has already labeled him as in spectrum or high risk, but the acceptance didn't come, it only came. So our role is to reduce that period of acceptance so that early interventions can become much, much easier and give better results to the children. Generally, this is the order, but sometimes no other specific, there is no specific, it can come randomly in any other way. But majority of the time, this is the order which comes in the stage of Elizabeth Kubler-Ross stages of acceptance from grief to acceptance. So counseling plays a very important pivotal role. Now, I just give you a simple case scenario. A child, 3-year-old child comes into your OPD practice and the mother complains of all these following things: no name call response, hand flapping, eye contact, no recognition of parents, aloof, no play skills, stimming. And you observe all this picture in your clinical OPD practice that all these things the child is doing. And so suddenly what comes in your mind? There is no, whatever tool you apply that clearly gives a picture the child is on the autism spectrum disorder, irrespective of the fact whether you apply or not. As I've told you, it is more of an observational finding. Tools which you apply, they just support your observational findings. Without looking the child, if you directly use the tools, ESA, CARS or EDOS, then there is no point. You can mislead the parents, you can put a false diagnosis, or you can underestimate the diagnosis. So important thing is observe the child first and then use these tools, because these tools help in matching your observational skills. They help in supporting your observational skills. So if you use this child, if you observe this child, you can clinically say that, yes, your child is on the autism spectrum disorder. So a simple way to put across this word of diagnosis to the parents is, as a pediatrician, you might tell to the parents, oh, all these symptoms appear to be the child, your child is on the autism spectrum disorder. It's a lifelong neurodevelopmental disability. He will need assistance throughout the life. Start with the therapies. He needs multidisciplinary approach, ABA therapy, OT and XYZ. And we might prescribe him some medications, maybe Shizodon and etc. for his behavioral issues. So we might finish up this concept of labeling a child on autism spectrum within a period of 15 minutes or maybe 10 to 15 minutes. So very true. You have made the diagnosis absolutely fine. But we have not done a proper counseling. We have not disclosed the diagnosis of autism in a proper way. Also, this parent might not turn up to you again at all. And he might not feel good. He might go with a sense of depression, grief, and anger from your clinic. So whenever you have to use, important thing is whenever you are giving across these diagnoses, putting across these things to the parents, one important thing, caution which you have to maintain is avoid using the terms like disability, avoid using the terms like lifelong, avoid using the terms like lifelong assistance, avoid using the terms like neurodevelopmental disorder. I'm not saying that these are not these conditions. These are all the problems that they will face. But my concern, my idea is to put across the words which mean the same like this, but do not use these words directly. Got my point? So instead of neurodevelopmental disorder, we can use these words neurodiversity. Now let's understand this thing. What is this neurodiversity and how we are evolving around these words? So avoid using these terms like disability, lifelong assistance, and neurodevelopmental disorders. So whenever you are disclosing the diagnosis to the parents, so this is a typical scenario which I have shown you in the previous slide. This is how you put it there. Your child is on the spectrum. He requires this and this and this and this. So this is how we put across the diagnosis. But now let's make it in a more, sophisticated way, how you can disclose the diagnosis. So before disclosing the diagnosis, one most important thing you have to remember is this is what we call as a pre-disclosure preparation. Ensure a private and a comfortable setting. The clinician should be confident enough to handle all the questions. This is very, very important. And you never lose your temper and get irritated with similar questions being repeated multiple times. Schedule sufficient time for the conversation, at least 30 minutes should be given. If you are in a busy practice, it's better avoid using those words and tell, okay, we'll review after 3 weeks, we'll review after a month, and advise reduce screen time or XYZ, explore play area and XYZ, whatever you can think. But make sure you have a sufficient time. So schedule the appointment when you have a sufficient time of conversation. Have relevant information and resource ready. Consider involving both the parents. It's better always include as many family members as possible and be prepared for multiple reaction as I've told you because they might never turn up to you again also. So these are very, very important things which you keep in mind while preparing, while giving across the word diagnosis of autism across the parents. Now, another important thing is you always start with empathy and support. See, I am also putting a word like autism to the parents, but I'm putting it in a different way rather than putting across in a very straight way. So example, I want to acknowledge your concerns and thanking you for trusting with the child care, but provide a clear and concise diagnosis. First start with a, okay, I do acknowledge your concerns, what you're facing, but as per a diagnosis and as per a clinical picture, what we observe as a team is through evaluation that the child might be having or the child appears to be in the autism spectrum disorder. Rather than appears, you can use the child on the basis of clinical observation, the child is suggestive of autism spectrum disorder. And you can also put across that how this ASD can affect the communication, social interaction, behavior. Now, telling the problematic things is good, but along with that, you also need to tell them there are some positive aspects also in these children. And also, stress the importance of early intervention and support, how it can significantly impact the development of the child. That is why, as I've told you, because this early intervention, we use the word early intervention till the period of 3 years. No doubt now the therapies can start it even at 4 or 5 whenever the child comes. But the concept of early intervention is from birth to 3 years. That is why we stress the importance of early intervention because because of that importance, you need to reduce that period of or the stage of grief to acceptance to the minimum phase so that early intervention therapies can be involved as early as possible. So there is a very important saying which has been given by Dr. Stephen Shaw. If we have met one child with autism, we have met one child with autism. There's a famous quote by Dr. Stephen Shaw. That means to say, no two children on spectrum are the same. Hence, said that depending upon the observational skills which you find, some children might be having a lot of stimulation. Some children might be having a lot of behavioral issues. Some children might be on the mild spectrum, or which we were using the word Asperger's syndrome or high functioning autism. So depending upon those scenarios, the child might predict or the child might clinically behave in a very different way compared to another child. So you need to discuss the concept of neurodiversity and inclusion to the parents. Now, before going to this neurodiversity, we should understand what is exactly is neurodiversity. So rather than putting a word across of neurodevelopmental disorder, you can use the word autism spectrum disorder is now considered to be a neurodiversity of the developing brain. It is a variation of the normal developing brain. When you use the word normal, it gives them a sigh of relief. You're not denying that the child is not on the spectrum. You are not denying that the child is not having these behavioral issues. You are not denying that the child is not having these communication issues. But you are just putting a one word across which gives them the sigh of relief and some relaxation that it is a variation of the normal developing brain. Now, this something which I'm using the word is not a false belief which we are giving. It's a proven fact. Now we are considering rather than a neurodevelopmental disorder, which is our traditional textbook language, we now use the word neurodiversity as autism ASD is now considered to be the neurodiversity of the developing brain. Now let's understand what is this neurodiversity. Because before putting this information across to the parents, we as clinicians should be well versed with this information. So what is neurodiversity? So these are some of the important facts which I want to share in this slide. According to the Harvard Medical School, neurodiversity describes that people experience and interact with the world around them in many different ways. There is no one right way of thinking, learning, and behaving, and these differences are not viewed as deficits. And the word neurodiversity refers to the diversity of the people, which is often used in the context of autism spectrum disorders, other neurological developmental disorders like ADHD, learning disabilities. So, taking into this fact from the Harvard Medical School, we should consider this that these are not considered as deficits. It is every child, every person in this world has its own way of perceiving the world. And there is nothing right, nothing wrong. It is only just the human nature which we have created that if you are holding the pencil in the right way from the right hand or writing from the right hand, that is right. That is socially accepted. If you are writing from the left hand, that is not socially accepted. But this is not wrong. Exactly. If you're talking in a very polite way, that is socially accepted. But if you're talking in a very harsh way, if you're not able to read the facial cues, that doesn't mean that it is wrong. It is right, but it is not socially accepted. That is what. So ASD is something which is not socially accepted. But ASD is not something which is not right. You got my point. So it is not socially accepted by the humans, but it is not wrong. That is what exactly the Harvard Medical School emphasizes. The neurodiversity is something in which a child or a person experiences the world in his own way. There is nothing right, there is nothing wrong, and there is no way of right that you should do like this, you should perceive the world like this. Hence, taking to this concept, we now include this ASD, ADHD under neurodiversity of the developing brain. So as per the World Economic Forum, which was conducted in 2022 in, I think, in Geneva, so what they told that neurodiversity is a non-medical umbrella term. It's a very, very important take-home message that neurodiversity is considered to be a non-medical umbrella term that includes the conditions like autism, dyslexia, dyspraxia, dyscalculia, and ADHD. Reference I have put across, it was done in 2022. So another important fact which I'm putting across here is this: teams with neurodivergent professionals can be 30% more productive than those without them. But there is a greater incidence of mental health difficulties like anxiety and depression among neurodiverse individuals. We always talk about the problems they face. We always talk about the deficits they face, but we never talk about the facts. We never talk about the facts that how good their qualities are, or the good qualities, the strong qualities which they have, which put them across, which put them apart, or give them an edge compared to a neurotypical population. So these are the facts which I have taken, that teams with neurodivergent professionals are 30% more productive. The reason is because they are hyper focused. The second reason is they are very obsessed, which we use the word fixations in a negative way. So these are, and some of the facts, they are hyperlexic. Hyperlexia is a term which we use where the child has the ability to read particular thing much beyond the concept of his peers. There are so many children on ADHD and ASD which can read encyclopedias, which can read so many books within 5 to 10 minutes and can tell you the description of all, where a child on a neurotypical spectrum might not take 1 hour to read that similar thing. So that is what we talk about hyperlexia. That is what we talk about their important productive skills, which we consider it as a negative deficits. According to the World Economic Forum, everyone is different. There is no single right way when it comes across to learn, think, and behave. So neurodiversity is a concept that describes these differences. So these differences, challenges, and strengths should not be considered as deficits, one of the most important things. So between 10 to 20% of the global population in the world is considered to be neurodivergent. This is the research which has been done from consultancy and auditing firm Deloitte. So the term recognizes the fact that certain developmental disorders are normal variations of the developmental brain. So these are not considered to be the neurodevelopmental disorders, lifelong disabilities. These are the normal variations of the developing brain. And hence said that they do also have some difficulties in the form of communication deficits, in the form of behavioral issues, in the form of doing activities, that is activities of daily life. Said that, they also have a lot of strengths. So some of the facts again from the World Economic Forum: autistic brains are highly creative with exceptional concentration, logic, imagination, visual thoughts. That is why I said that we know that there are two different ways of learning: auditory learners, visual learners, and kinesthetic learners. Visual learners is the way where they learn through they learn through visuals. That is why autistic brains, they have a very good brain mapping, and they are very strong visual learners compared to auditory learners. They are very poor at auditory learning. No doubt, visual learning is much better compared to auditory learning. But definitely, if we look into the neurodevelopment, neurotypical population, there are so many people who are very good auditory learners. But it is the gift of God, or it is by the virtue of nature, that autistic brains are very strong visual learners. Because of the strong visual learners, they have strong brain mapping, and because of that, they are highly creative. And that highly creative nature with exceptional concentration, we have put a word across earlier, which is as per the DSM-4, which we use the word like Asperger syndrome, or you can say there was another word, Asperger syndrome, yes. But now these words have been obsolete. Now we use the term only mild, moderate, and severe. So mild autism means higher functioning, or you can use the word Asperger, but now we don't use them as per DSM-5. So people with ADHD have great imagination and score higher on creativity tests than non-ADHD people because they're hyper focused. Now we use this word as hyper focus as obsessions or fixations. So dyslexic people have demonstrated the ability to think out of the box. 84% of dyslexic people are above average. So if you do the IQ testing of the dyslexic children, 80 to 84% of them are above average in reasoning, questioning, understanding, and evaluating the proper and decision-making concepts. So this is according to the charity which is made, according to the charity made by dyslexia. So these are some of the important facts which I need to put across when we talk about ASD, ADHD, or dyslexia. And these are some of the top MNCs which are hiring autistic individuals. The Dell Autism Hiring Program. This is the data which has been taken from 2022. So they are hiring. Ernest and Young is there, JP Morgan is there, Ultranauts is there, Spectrum is there, and Aspetech is there. These are some of the very high good MNCs which are hiring autistic individuals. So it is not like that they have been dropped out from the population, or they have not been given important consideration, or they cannot do anything in their life. They always need support and dependence. It's nothing like that. So these are some of the important facts which you need to put across to the parents, so that it gives them a sigh of relief. It also gives them a hope that nothing has happened. The word autism has not changed their life. There should not be something which they should give a setback. Definitely the journey will be challenging, but it's not like that. That's the end of the journey. The whole concept of counseling should be that the parent, after getting a counseling and a diagnosis, should not go from your chamber thinking depressed. He should feel more challenging, that yes, now I'll face this challenging journey and I make my child something independent in his life. That should be the motto, and with that motto he should leave out to the room, and not with a depression and anxiety that next day he's on antidepressant pills. So giving you about all this slide and showing you all this thing, the end of the result is, can we now tell that dyslexia, ASD, sensory issues, all these which are coming under neurodevelopmental disorders, are considered to be the normal variations of the developing brain? So now if we go into our medical textbooks of definition, autism, what is autism? We used to read always like that. Autism is a neurodevelopmental disability of variable severity with lifelong effects that can be recognized early from childhood, chiefly characterized by difficulty with social communication and with repetitive restrictive patterns of thought and behavior. So if you put this definition across to the parents, you see what impact will go into their mind. And if you put this word autism with the neurodiversity as per the World Economic Forum and our understanding, changing understanding of these autism spectrum disorders, you see how different your effort will go into the parents' mind. So it's probably an high time that we need to think about revising these definitions of autism in our original textbooks of Nelson and etc. Maybe over a period of time, this might not come into our seniors, or maybe changing, but the important thing is how you should represent the diagnosis of autism across in a communicative way to the parents, so that they are able to handle that situation. So said that, you can also describe about the problems, motor difficulties, sensitivity issues, repetitive behaviors, communication. And definitely we will describe them to the parents. But along with these problems, we also need to stress about the strengths of these children that we'll share across. So you keep a small pictographic representations in your chamber, because it's very, very difficult for the parents to absorb all the abstract. Once you have put the word autism, they will not be, their brain will shut down. Whatever information you give to them, auditory information, they will not able to go into their mind. So try to give them more visual cues, more visual pictures. Prepare small charts in your OPD. Now, this is typically for those pediatricians who are very much inclined towards the developmental pediatrics. If they are doing their general pediatrics, it's very, very difficult for them to give that much time. So it is very, very important that how you're interested in which area. So you need to give an ample time of at least 30 to 35 minutes when you are dealing with such scenarios in your clinical practice. So prepare some pictographic representations of these. Suppose there's a child, if you say your bacha aloof rehta hai, wo nahi sunta, it becomes difficult for them to understand. Give them a pictographic representation. See, these are two kids who are playing, and this alone child is not interested at all in playing with those children. This child is playing, he's just stimming, playing with his fingers, and these two children, he's not at all interested in peer play. He's avoiding an eye contact. So it gives them a better understanding of autism, because the word autism doesn't give them an understanding what exactly happened. He's absolutely normal. He was a normal term, cesarean delivery. He was absolutely fine till 2 years. Then what suddenly happened within this 1 year that is suddenly lost? So you need to make them understand. We use a word regression autism, but yes, we do. Even if you don't want to go into more technical terms, you can even just put a word across autism, but you need to make them understand what's exactly happening. So you can prepare like this: communication social deficit. There is a child sitting in the crib. Mother is shouting, but he's not at all responding. There is a typical stereotypic movements are there, rocking movements, looking at the fans. Then there might be sensory issues, bursting of the balloons are there. They are not comfortable with the tactile, the texture. And the child is putting a hand in the cake and he gets so much irritated, texture issues, lining up the toys, typical stimming behaviors, verbal stimming, they keep on hanging, rotating fans, fixations with the rotating objects, not comfortable with wearing clothes even in winter and summer, so tactile issues, texture issues. De- Describing all these negative facts is absolutely fine. But said that you also need to give them the positive facts. What are those positive strengths? They have a unique humor. They are very honest. They are desire to connect. Many a times we see that वो बच्चा जा रहा है उसको push कर दिया and the teacher complains वो बच्चा push कर रहा है आप अपने बच्चे को संभालो. You need to understand it's his way of non-verbal communication. You are not giving, you are putting him across, you are not involving in the activities, you are just holding and putting across at the corner of the chair. He will get irritated, he will push. Pushing is not a behavior. Pushing is basically his constant. Pushing is basically his a way of non-verbal communication that I want to involve into the activity. I also want to play. So that is I need to understand the psychology of the child, how he's doing. A basic concept of behavior management is you need to anticipate what is the cause for the behavior. But unfortunately, we always target the behavior. The child is pushing, so just stop him from pushing. Why he is pushing, we not see that. He is just pushing, stop him. So the thumb rule is follow ABC, antecedent, behavior, and consequence. ABC approach for behavior management. So this is very important. So honest, desire to connect, fair and just. They have intelligence, spatial interest. They have visual. They are very strong visual learners. I have told you they have very good memories. They are actually strong visual learners, so they are actually have a very good memory. Even if you kept a small thing at the corner of the house, they will remember it always, even after a year. So they are hyper focused. They are very detail oriented. They want to do these things exactly like that. If red color is first, it has to be red. It cannot be yellow. They are very meticulous about the cleaning of the particular area. It has to be kept like that. But we take it as a fixation. We take it as an observations, obsessions. We take it as their obsessions, fixations. So why not we take it as their strengths? They want to keep the things in a proper way. And this might help them in assigning. This might help them in doing mental tasks. This might help them in doing the office tasks. This might help them in cleaning their cabins and XYZ. There are so many things. So we always tend to forget the possible strengths in the kids. We only try to focus on difficulties and try to correct them. Rather than trying to correct the deficits, why not we make their strengths even more better so that they can lead and become an independent person in their life. So quote some examples of famous personalities at the end when you are giving a counseling. Albert Einstein, he was a scientist and mathematician. He's a famous personality who's having ASD. Charles Darwin, Bill Gates. Bill Gates, at least everybody must be knowing that he's also on the autism spectrum disorder. Isaac Newton, who is a mathematician, who was a strong mathematician astronomer, he was also on the spectrum. Ilan Yusuf, he's a famous entrepreneur. Leonardo da Vinci, who was a famous artist, who was also on the spectrum. So quote some examples of famous personalities so that at the end of the day, when the parents are going out of your chamber, they should go with a good faith. They should go with a strong, challenging nature. Yes, I will do that. Rather than on the next day, they are going to a psychiatrist and taking antidepressant medications because that will not help them at all and not their child. So at the end with this, I just tell post-closure support is when you have put across the diagnosis, when you have tell all these things, be offer emotional support and reassurance, provide them with good information and resources, and tell them, highlight the importance of early interventions. And always schedule follow-up appointments. Not like that you have just tell, okay, your child is in the diagnosis, start with early intervention therapies, and then always get in touch with the parents, call them for regular follow-up so that they always feel that a sense that yes, the doctor is connected with us. He is the first doctor who had give them the right guidance. He is the first doctor who would tell us that yes, he's on the spectrum. So remain in touch with them. Definitely, you can't do much about that. It's now it is the role of interventions, but at least they will know that yes, the doctor is caring and he has kept us touch with us, and he's he's interested to know what is going better with my child. So keep a regular follow and encourage open communications. So with this, I will end with the presentation today. So it was a quite brief presentation as the time allotted to me was that much. So thank you everyone. And over to you, Kavita ji. If there are any questions, we can take across.
Yeah, thank you so much, Doctor. It was such a wonderful session. I'm sure all of them who have joined have benefited out of it. It was such a wonderful session. Just wanted to know if somebody has any kind of question or query or any probably discussion with Dr. Lalit, please, you could put it on chat or you could even unmute yourself and ask the question.
Hi, I'm Dr. Harika here.
Yeah, doctor.
Yeah. So my question is like, when I see general pediatrics, I see some children with red flag signs, and parents are in denial. Do you have any technique to convince them to come back for an assessment?
Can you repeat your question again?
When we see a child with red flag signs in a general pediatric OPD,
Okay.
like parents are in denial when we call them for an assessment. Do you have any technique to, tell them to come back so that we can help them out?
Exactly. See, rather than as I have told you in the previous slides, that autism spectrum disorder is something which is more of a clinical observation.
Mm-hmm.
Whatever tools, whether you use ESA, whether you use CARS, whether you use PABs, whether you use reels, whatever tools you use, they just help in aiding your observational picture. See,
Okay.
so rather than going directly that you can come on to the next visit, we will do a complete evaluation of the child. That gives them again a sense of, discomfort. Complete
Mm-hmm.
evaluation, what they will do. They will check my
Mm-hmm.
child from top to bottom. They will do his assessment, speech, and that will
Mm-hmm.
take definitely 2 hours, maybe 1 hour. Now,
Okay.
that fairness will always be there. What is happening inside? The husband
Mm-hmm.
and wife might be discussing what after 1 hour, what the report will come. They will say, no, don't worry, it will be normal. It might, what happen if it doesn't come out to be normal, if it goes below the average, IQ testing, all those things. So rather than going into that picture, it's better that you can tell them. Suppose on the first visit, you see early red flag signs like not babbling or not responding, whatever early red flag signs. Definitely will tell them, okay, revisit after 3 months, reduce the screen time, involve more of a peer play. And then after
Okay.
3 months, when they come, rather than you going for a complete assessment, just tell them, I am suspecting some early signs. And
Mm-hmm.
instead of using the autism, I am suspecting some red flag signs which are going little away from the normal development. So
Okay.
here I am not using the word autism.
Okay.
I'm just telling that I'm seeing some red flag signs which are going out of the trajectory of the normal development for this child. So just
Okay.
keep a check on this and do these things as advised by me, and then review after 3 months. And then once you review after 3 months, definitely if they're improved, he's unlikely to be on the spectrum. Probably he was a virtual autism because they might have
Okay.
reduced the screen time and peer interaction might have
Mm-hmm.
increased, parents might have involved more time. It has come down. But if it is
Okay.
actually a true autism, definitely the picture will increase. That is
Okay.
for sure.
Got it.
And
Yeah.
then when the picture increases, you are in a better position to tell them that now it's the time to tell the complete complete evaluation of the child, and they will
Okay.
accept that at that time.
Okay.
Okay,
That's very helpful. Thank you.
thank you.
Hello.
Yeah,
Yeah, I
hello.
have a question. You just talked about, regression of milestones. So is it likely that in autism, for example, a normal child growing normally till age 3 years, 2.5 years, and then, they show signs of autistic features like speech delay, repetitive behaviors, or social communication disorders. Is it possible in a normal growing child and then after some time to show, features of autism?
Yes, sir. See, sir, up to the regression autism is something, generally speaking, the signs of autism becomes visible only after the age of somewhere around 2 to 3 years. Initially, though,
Okay.
definitely they will be signs will be present as early as 6 months, right? Reciprocal imitations might not be there. The child might not
Okay.
respond by pointing might not be there, but generally those are going underestimated, or we do not give a botheration to them unless and until the child reaches by the age of 2 to 3 years, when his mingling gets affected, social interaction gets affected, he's not involved with other
Uh,
children. So, so said that, it's not like that the autism picture is not going initially also. It is going there also. But it becomes more evident by the age of 2 to 3 years
okay.
because of the concept of this synaptic pruning. Okay.
All
Now,
right.
autism regression is also a
And
word
one
where,
more
yeah,
question. Yeah,
yeah,
yeah.
yeah, please go ahead, sir.
Yeah, continue, please. Yeah.
Yeah. So I was telling about the
Yeah,
regression
I have
autism.
one more question. In fact,
Yeah.
regarding the, test. Okay. Yeah, in your experience, do you proceed with any genetic test for, autistic children coming to you? Any instance of, genetic genes, deletion and other things associated with autism, other than, simple things like Down syndrome or fragile X and other things?
Yeah. So there is there are actually a complete guidelines on going into when to do a genetic testing for an ASD kid. So just
Okay.
to give you a crux about that is, there are certain parameters which we need to look before going an ASD genetic testing. As per now, as per the latest recommendations, genetic testing is not mandatory in every ASD kid.
Okay.
Genetic associations might be there with ASD kid, might not be there with ASD kid. Earlier was there the
Okay.
genetic association has the maximum association, which was giving
Okay.
figures of corresponding more than 50%. But now said
Okay.
that the environmental variations, the concept of what we call as this what is epigenetics, it has become more and more evident.
Uh-huh.
So, epigenetics, where the
Okay.
genetic involvement is there, but the variation of expression of the genes is affected, but it is not affecting the genes permanently. So, it is not a genotypic expression, it is only giving you a phenotypic expression. So, that means to say when you go for the genetic testing, they won't be affected the genes at all. So, now for your question, for the genetic
Okay.
testing, either there should be some picture of dysmorphic appearance should be there. There should be some family history of siblings which are affected with some syndromic picture. There should be some abnormality in MRI and neuroimaging, or there should be some
Uh-huh.
picture of similar sibling having an ASD. Okay. So
Okay.
based on these facts, if you get
Yeah.
any of these above findings, then you can go for a testing. Now, even for going for the genetic testing, there are different stepwise. You cannot go for immediate microassay testing. You cannot go for immediate hi-fi testing. So initially maybe you can go for a WS, or you can go for Fragile X if the picture gives you an appearance. So rather than saying that it's not a blanket
Okay.
therapy that for all ASD kids, you need to go for a genetic test.
Okay. Thank you.
Okay. Thank you. Thank you, sir.
Dr. Lalit, we have some questions in the chat. Can I pick it up one by one?
Yeah, please,
Yeah,
Miss.
this is from Dr. Mansoor Ali Khan. He says ASD is a clinical diagnosis. Is there any investigation, non-invasive, to confirm the diagnosis?
See, there is no non-invasive clinical test to confirm the diagnosis of autism. Even the worst or even the severest of autism picture will give you complete normal testing on labs. Might give you, it's not always, might give you. because there might be some associated micronutrition deficiency. This might be associated gut deficiencies, gut disturbances. So there, the lab testing which is done, it is done to look for the associated problems. But to confirm the diagnosis of autism, there is no clinic testing. The confirmation of the diagnosis of autism is on observation and on the various tools to support your observation, but not to confirm the diagnosis, to support your observation, so that what observation you are doing is absolutely fine and getting documented on the picture.
Okay, the next
No.
question goes with this. He asks when to pick up the diagnosis as early as possible and how frequently to follow up with such patients. And
Two
what is the
labels.
person?
There
Sorry.
are two different aspects in this. As early as you can pick up the early signs of autism as early as 6 months. A 6-month-old child will give you a typical reciprocal imitation. For example, if a mother keeps a 6-month-old child in his lap and looks at her, gives a smile, the child will always look at back to the mother and gives a smile. This is a typical example of reciprocal imitation which appears as early as 6 months. If this sign is missing in a child, probably the child might be going into a spectrum in the later stage. So the first part of the question is you can pick up early signs of autism as early as 6 months. Once you pick up these signs as early as 6 months, then you can go for a regular follow-up after 3 months and keep a check on their developmental milestones, especially the three important things. Look for creeping, crawling, and walking movements, because generally there is a concept of primitive reflexes retention. The primitive reflexes does not integrate in these children of neurodevelopmental disorders or neurodiversity, including like ASD, GDD, or maybe ADHD. So as a result, their STNR, ATNRs remain integrated, remain retained. They do not get integrated. And because of the fact, many of the times you will get a history that from creeping, crawling, he missed that stage of creeping or crawling and directly started walking. And the walking will also be delayed, though it might be well attained within the target age of 18 months, but it might be at 15 months, it might be at 16 months. So you will get a typical history of the crawling was missed or creeping was prolonged up to the age of 12 months, and then he suddenly started walking, or he didn't do any creeping or crawling and missed and started walking. So whenever you get this picture, always look for these developmental milestones. So this is one part. You can pick up early signs of autism at 6 months. But when can you make a diagnosis of autism? The earliest diagnosis of autism can now be made at the age of 15 to 18 months, because CARS is a tool which can be used between 15 to 18 months. But the new MChat modified R, which can be used somewhere around 2 years, which is a screening tool. The major drawback is that by the age of 2 years, before the age of 2 years, we cannot use MChat. Though you can use it, but as per the guidelines, they say that 24 months around you can use that. So MChat is something which can be used for mass screening. But if you go for an individual screening, you can pick up the diagnosis as early as I have told you, by 15 to 18 months. You can directly apply CARS if you feel the clinical picture of red flag signs are appearing in the child on your clinical observation. So there is no need to go for MChat. If you are confident enough, you can directly apply for the this CARS or ESA. ESA is also equally sensitive. The advantage of using is that you are reducing that typical period of 2 years from 18 to 2 years till the time you are going for the MChat testing. So you can pick up that 6 months early pickup will be very, very helpful for early intervention services. I hope I have answered your question.
Thank you, Doctor. Dr. Mansoor Ali Khan also has one more. What's the percentage of cases who turn up normal in follow-up after the diagnosis? So he's basically talking about the mild cases.
See, there is nothing about normal. There is nothing about normal, as we have discussed that. And autism is something which you can treat. Normal thing comes which you are treating. You can treat diarrhea, you can treat infection, you can treat dengue, you can treat enteric. There you can put a word across that after treatment the child become normal. So what is the frequency of enteric fever treating getting into normal after treatment? But here there is no data, because they are not abnormal or they are not normal. Even if I give all these intervention, they will not turn out to be normal. The brain which is there, it will set that. What we are doing, we are just manipulating the brain so that their concept, their way of thinking, the brain becomes little more socially accepted. We are just modifying their way of thinking. We are not treating them. So there is no concept of how many percentage of children are getting normal. we can use this concept in virtual autism. But said that there is no data on virtual autism, that what is the percentage of children after reducing the screening for 3 months getting into a normal neurotypical spectrum.
Thank you, doctor. And one more question is, which diseases are associated with the ASD?
Diseases, you mean to say, what diseases you mean to say? I mean, comorbid condition, they can be genetic problems, they can be Down syndrome, they can be Klippler, they can be associated problems like anxieties, they can be gut problems, they can be associated dyslexia problems, they can be learning disabilities, they can be gross motor deficits, they can be fine motor deficits, they can be psychological problems. So all these problems are there. So these are the comorbid conditions which are associated with ASD.
In case of any mental disorders, are there any common in such patients, he asks, and how to treat them with drugs? Should we refer them to
OCD,
psychiatrists?
you see, OCD is one of the major problems, which is their tic disorder is there, which can be associated. Seizure association is there. 25% of the children with autism spectrum disorder might have seizure disorder. Sleeping issues is a problem. So yes, for these things, generally, if a developmental pediatrician is well versed with these concepts, he can manage them. But if still you are not confident enough, yes, definitely we can refer to them to a psychiatrist who is well versed with treating these children associated problems.
Okay, thank you so much, doctor. Any other questions? If anybody has, please let us know. If not, we could wind up the session. You could unmute yourself and ask the question.
Yeah. Hi, good afternoon. This is Dr. Asma from Sharjah. Thank you very
afternoon.
much for a very impressive and very brainstorming session, because most of doctors, they don't even know much about how to cope up with the implications of ADHD nowadays. Specifically, when they're talking about vaccines being causing, after post-meningitis vaccine, people say that it is one of the reasons some of the kids after meningitis vaccine get this. Is it a reality in it? Have you heard about it? When I was in Canada?
No. There are no association of vaccines with autism.
Okay. Secondly, when are we expecting these children to be assessed? How often these children to be assessed by the experts? Is it monthly, yearly, or
See, generally,
when
the
do we
assessment,
expect it?
See, generally, if we do for the development screening, they say that's 9 months, 12 months, 15 and 18 months. That is a normal development screening which we do. Now,
Okay.
this is so definitely 9 months, 12, 15, 18 months is the normal development screening schedule, which should be done where we can do a regular checkup for the children by clinical observations. Are there any deficits? Are there any things which are going away from the track? So 9, 12, 15 and 18 months is the normal developmental checkup which you should looking into all the developmental milestones, gross, fine, social, language. Now, if you feel, as I've told in one of the doctors I've asked, how early we can pick. As I've told that by the age of 6 months, we can pick up the signs of autism as early as 6 months. Suppose if at 6 months you are picking up certain signs in child, now from there onwards, you can do a regular follow-up after 3 months. Okay.
Okay, thank you. But
Yeah.
do we expect these children to get better in due course of time? And can they have a normal after what age? After what age?
See, the majority of the problems, the major consequence which we face in adolescence age group is the anxiety and depression.
Okay.
This is the major consequence of ASD, anxiety and depression. The major causes because they are not very much comfortable with the social interactions. The social interaction is one of the major causes which affect them anxiety and depression. So probably in the ages of 20, if we need to give them some antidepressant to reduce the anxiety and to improve their social scenarios, social skills, to reduce their social anxiety, then at that stage it is not a harm, depending upon if we are keep on titrating the dosage. As we know, suicidal tendencies and all those things are the major side effects. So that is why early adolescence is not the right age, because they also go with the hormonal changes. It also becomes very difficult for them to adapt this transition from childhood to adolescence, because there itself gives them a lot of anxiety, emotional dysregulations. So contrary to that, if we add antidepressant, that will create a nuisance to their life.
Sure. So now secondly, I've seen patients who were hypothyroid, and they were later on diagnosed because at point of their age 25, 35, they were told that no, you were also having this autism earlier, but it was missed. Um, do we find such cases in later life than they are because of anxiety disorder? They were being tracked down retrospectively, and they were told, "Okay, look, this is the problem which is initiated in your during childhood, and we cannot
Could
do
be
anything about it."
could be a problem, because hypothyroidism is a common association with GDD, is a common association with autism also. It could be a
Yeah.
GDD at that time, but later phase it turned out to be ACE, because GDD is something which we use the word till the age of 5 years. So beyond 5 years, you cannot use the word GDD. So the GDD
Mm,
has to be converted in something, either it is a autism or ADHD or LD or dyslexia, whatever it is. So probably it might be
mhm,
an evolving GDD, and later it might have turned out to be into a spectrum.
mhm. Okay, is there any study on relationship with insulin resistance and autoimmune thyroid with autism?
I need to look into that.
Because what I'm an IVF specialist here, and I see the kids which I've seen now they are grown up. My first IVF baby is now 29 years, and few of the cases I saw, husband, mother, and father, they had B12 deficiency, known B12 deficiency, and when this child was diagnosed as autistic, so they said no, father was also having the same issue, but he got better. Now he's an engineer, but he focuses one thing at a time, but other than that, he's completely normal. So I said maybe you use the word epigenetics. So we are more in epigenetics nowadays. So can we do some prevention on genetic, balancing before we treat these patients in IVF? Because when we have a mother and a father and a history of autism in the family or hypothyroid related autism in the family, sometimes insulin resistance is also seems to be related. So far, I have not come across any data, but I've seen patients of these polycystic ovaries, gross polycystic ovaries. They have these kids which they claim that initially no eye contact and later on they were difficult children. So I thought
The
I might ask you a question with your
Yes,
experience.
yes. The probable reason for this is that they have an alternation of the gut microbiota.
Oh,
So,
okay, fine.
so alternation of the gut microbiota in the pregnancy is one of the most important cause, which ultimately alters the microbiota of the child. And probably
Mm,
it alters the microbiota, and probably they might go into a cesarean section rather than going into a normal vaginal, probably because of the
delivery.
XYZ reason, medical
Mm,
issues, and that conversion of the microbiota from the skin to the cesarean alters the microbiota of the child, and that alters the whole
mm,
picture. So there, the concept of LPS leaking, cytokines, and XYZ. So here comes the concept of epigenetics. Epigenetics, how the environmental factors and expression of the genes affect, that affects the
they
gut
do affect, yeah,
microbiota. Yeah.
yeah,
So this whole
exactly.
process starts from the conception. So as an IVF
Hmm.
specialist, so you can, ma'am, definitely guide them on the balanced diet and alteration of the gut microbiota. You can provide them with some good, strong probiotics during the
Mm,
antenatal period, along with the antibiotics during the UTI or XYZ infections. That might help
mm.
in altering the gut microbiota of the child
Yeah, this
and the
I'm
mother
doing
before
for
that.
last 10 years. This I'm doing it for last 10, 12 years because I was into the cell health and, holistic health attitude towards all the diseases. One part is allopathic line of action. The other was holistically treating the cells to be healthy and happy. So
Yes,
again,
yes.
this gut microbiome now is coming up, but initially we were thinking there is some relationship of the gut flora related to all these diseases. Every disease is related to the gut microbiome. This
Very
is
true, very true,
what my observation. Well,
very
thank you
true.
very much, doctor, for this very refined talk. We
Thank you,
are
thank you,
honored to have your talk, and we would be expecting more on in such similar topics which can help us in clinical evaluations. Thank you very much.
thank you so much. Thank you for your kind words. Thank you.
Thank you.
Thank you, Dr. Lalit. One last question we will take, Dr. Lalit.
Yeah.
Which other therapists are needed in such patients?
Which
Last
other,
question.
which other,
Which other therapists are needed for such patients? Like speech
which,
therapy, like
okay.
a lot of
So,
other
so it's,
therapists.
as I've told you, it's a multidisciplinary approach. You need to have, first of all, definitely the first counter will be the pediatrician. You need to have developmental or a pediatrician, whatever you can take. You need to have a strong counseling team. You need to have professionals like OT, occupational therapist, speech therapist, behavioral therapist, special educator, and not forgetting the concept of play therapy. Now, play therapy is something which is very underestimated in India, but play therapy is something which gives very good results in children, because play is something which gives the child motivation to speak, motivation to learn. Without motivation, you cannot teach an ASD kid, because there is also concept of theory of motivation. That's a total complete different topic, which we may get later in some other part today. So said that we need a complete list of therapists, a complete team, integrated team working on that particular child. Okay.
Thank you, Dr. Lalit.
Thank you.
So I
Thank you,
think we're
Kavita.
done
Thank
with
you.
all the questions. Thank you so much, Doctor, for patiently taking each questions and answering it for us. And I hope
Thank
we'll
you.
have many more such sessions in the future. Thank you so much for your time. And I thank all the participants for taking in time and joining the session. I'm sure it was very, very informative and useful to all of us. Thank you so much.
Thank you. Thank you, Kavita. Thank you all. Thank you.